Hello and welcome everybody to this live event, social media event, Emerging Therapies for MASH from Theory to Clinical Practice. My name is Jon Schattenberg from the University Medical School in Homburg in Saarland, Germany. And I'm joined by two experts here today. First up, Professor Naim Alkhouri, Chief Medical Officer, Summit Clinical Research. Hi Naim, thanks for joining.
Thank you for having me.
And second up is Maja Thiele. Thank you. Maja Thiele from the University of Odense, Denmark. Good to see you, Maja. Now, this social media event is happening live. We'll have a discussion and invite you to submit questions on the topic. I'm very much looking forward to your input. And without further ado, and to use the available time the best way, I'd like to advance and actually talk about the non-invasive tests and the fibrosis stages we have available to assess. We can see here that MASLD develops through different stages. Stages are at great risk of liver-related diseases and events. How do you go about your patients you see in clinic?
Sorry, was that a question for us, Jorn?
Apologies, I think my connection was down for a second. Yes, Naim, I turn to you asking about how do you assess your patients in clinic, actually?
Yeah, I think, a key point is to understand that MASLD is a spectrum, and I divide patients into three categories. So we have patients with early disease, we call it early MASH or just MASLD. And these patients, we need to focus on lifestyle intervention and optimizing the management of metabolic syndrome and type 2 diabetes to prevent progression. And then we have patients with MASH and F2, F3 fibrosis, moderate to advanced fibrosis. We call it at-risk MASH. And these patients we need to identify because they will benefit from pharmacologic treatment with approved medications now. In Europe, we have resmetirom as the first approved medication to treat MASH with F2, F3 fibrosis. And then patients with MASH cirrhosis, and these patients need HCC surveillance, and we need to see if they have clinically significant portal hypertension. So we have a specific algorithm for the management of MASH cirrhosis. So this is how I think about patients within the spectrum of MASLD.
And I think maybe I can continue.
Great, thanks for sharing, Naim. Apologies, some time lapse. Yeah, go ahead, Maja.
No, it was just Naim now mentioned kind of the importance of
Please
early
go
detection.
ahead, Maja.
So Naim mentioned the importance of early detection to prevent progression to the cirrhotic state where the majority of liver-related events occur. And so for this, we have now established international guidelines, which works across Europe, America, on how to, let's say, guide primary care for improving their referral pathways and improve early detection. So maybe, Jan, if you could go forward to the flow diagram. I think that the key part of the referral pathways is that individual liver blood tests are not enough for early detection of those at highest risk of progression to liver-related events. For this, we need composite scores or algorithmic scores. And the most obvious or most used one is FIB-4. So an easily applied score containing AST, ALT, platelet count, and age. So since age is a part of FIB-4, GPs and other healthcare professionals need to be aware that especially those with an age above 65, there's a risk for let's say, over diagnosing those with who need referral for fibrosis assessment. But in those with age below 65, the recommended cutoffs for FIB-4 are 1.3, 2.67, and then again the intermediate ones. So if a patient at risk for steatotic liver disease, for example, having type 2 diabetes, obesity, dyslipidemia, insulin resistance, if they have a FIB-4 below 3, it's enough to just monitor in primary care, repeat the test every 2-3 years to ensure that they don't show signs of progressive liver fibrosis. In those with a FIB-4 above 2.67, that's a sort of a red light and would indicate referral for further assessment using more accurate diagnostic non-invasive tools, typically liver stiffness or blood-based biomarkers of liver fibrosis. And then the kind of the gray zone area is a little more tricky. So those patients who have a FIB-4 between 1.3 and 2.67, they can be managed either by trying locally lifestyle interventions, focusing on control of the insulin resistance and especially weight loss management, as Naeem mentioned, the dietary intervention, the exercise, and then repeating the FIB-4 in 6 months, a year, for example. And if it remains high, above 1.3, then refer for more accurate testing. Or in places where some of these more accurate fibrosis markers are available, they can be used for those with FIB-4 in the gray zone or in the intermediate area. And this type of trajectory is recommended across the continents, and that's typically how we would expect primary care practitioners to ensure referral of those with steatotic liver disease at highest risk of progression.
Great, thank you, Maya. And of course, that includes the referral to experts, then the management by pharmacological therapies. And there's been some recent very exciting updates here with resmetirom approved both in the US and EMA and semaglutide. And that brings me to summarize that data for you briefly. As you are mostly aware, the thyroid hormone receptor beta agonist has been approved by EMA in June 2025. So we've had access for the last few weeks now, gathering experience. It has been approved for over a year in the US, and I'll be turning to Naeem again for some question about his real-world experience in a little bit, because he's had more experience here. But we can treat patients with non-cirrhotic F2, F3 disease based on non-invasive testing. I think that's a very important message. So no need for a liver histology, and the non-invasive test have been outlined by Maya to improve the liver disease. The second therapeutic, and there's been a lot of discussion around this group of medicines already. Semaglutide, the GLP-1 agonist, showed a positive results in phase 3 with improvement of the surrogates, hepatic inflammation and fibrosis. So FDA approved it in August 25. So the 2.4 milligrams of semaglutide are available for treatment of MASH with fibrosis. Again, only patients in the absence of cirrhosis are currently approved here, and EMA has submitted that, and I'm expecting to hear back by end of February, maybe. So that's great news, because I think it's important to remember that once you go to identify patients, you actually have to offer them something. And with that, I think the two drugs, there's a lot of excitement in the field to start treating the patients, but it also leaves room for more, particular patients with cirrhosis maybe. And Naeem, I'd like to turn back to you just to talk a little bit about future therapies and developments in the field.
Yeah, no, thank you, Jorn. It's very exciting to see that we have a couple of options now for our patients. We've had resmetirom for a year and a half, and we've had great success in the real world with good tolerability, low discontinuation rate, and we are seeing some preliminary efficacy data. Of course, the approval was based on the Maestro-NASH trial that randomized 966 patients with MASH and fibrosis, non-cirrhotics, as you said, to resmetirom 2 doses versus placebo. placebo, and the trial achieved both primary endpoints on MASH resolution and fibrosis improvement. These patients were treated for 52 weeks, so just 1 year, and the delta on fibrosis from placebo was around 12%, and this is reversing the disease. And then, the ESSENCE trial with semaglutide, as you said, with dose escalation to 2.4 milligrams weekly. This also achieved both primary endpoints, the MASH resolution and fibrosis improvement. And the delta on fibrosis regression from placebo was around 14.5%. And again, this is reversing the disease, and we are waiting for the data on preventing progression of disease to cirrhosis. So very exciting. We also have several therapeutic agents in the pipeline targeting different mechanisms of actions. We have what we call fibroblast growth factor 21 agonist, FGF21 agonist. We have PAM-PPAR agonists such as lanifibranor that is being tested in patients with non-cirrhotic MASH with fibrosis. And we expect the readout of some of these phase 3 data, toward next year and the following year. So we expect by the end of the decade that we may have 4 or 5 options to choose from for our patients with at-risk MASH.
Mm-hmm. And maybe I can add, talking about early detection, I think this will also create a landslide for primary care, because suddenly there will be an incentive for primary care physicians to actually diagnose patients. So I think that is a huge advantage of having new drugs on the market. It will simply create the incentive. So it's very exciting times we are moving against.
Agree, Maya, and thanks for sharing. And be reminded that even if you're outside of the F2, F3 range, which is the typical indication for treatment now, I think patients can really change the needle on their disease trajectory by applying lifestyle changes and physical activity, which are the baseline recommendations still, in addition to all those medications. I realize we have a few minutes left. I think we'll move to the next slide and discuss briefly which patients to select for pharmacologic treatment. Naeem mentioned some of that. We're not wanting to treat patients with cirrhosis defined on VCTE or ELF. There is a window of caution. If the VCTE is high, of course, these patients with advanced liver disease want to be treated, but you have to rule out cirrhosis and portal hypertension, and that's done, again, non-invasively, green light for patients that have those non-invasive tests equivalent with the histological stages F2, F3. So we're talking about VCT 8 to 15. In Europe and Germany, I can tell you we're going a little higher, 10 to 15 kilopascal range, highlighting that we want to hit the F2, F3 population. And with that, I think it's almost time to wrap up for us and maybe share some last thoughts in the remaining minutes. Naeem, what's your view forward on this?
My key message is, always to screen high-risk patients like those with type 2 diabetes. Once you identify that they have MASLD, you need to stage them and know if they have moderate to advanced fibrosis and they will benefit from pharmacologic treatment. Also, make sure you diagnose MASH cirrhosis, and then, again, start treatment in appropriate patients. I think this is a key message: screen, stage, and start treatment when needed.
Great, thanks. Maya, your 30 seconds. What's the wrap up for you?
For me, it's patient and physician education, because we have, as specialists, maybe been used to sitting back a little passively and waited for patients to be referred when they, for example, decompensated with ascites or peripheral hemorrhage, etc. And now what we really do is having the window of opportunity where we can treat the disease at an asymptomatic stage before all of these symptoms have developed. And I think so our opportunity and frankly, what we need to do as a hepatology community is educating patients and providers that liver disease progresses asymptomatically within the spectrum of liver fibrosis. And when cirrhosis, especially decompensated cirrhosis, sets in, the window may have closed. So I think that's an important thing.
Thank you, Maya, and thank you, Naeem, for sharing those insights. Again, MASLD is a relevant disease to our patients. I think we're here to test it and stage the patients non-invasively, treat them appropriately, and I think this is a strong way forward. Thanks you both for joining tonight. Also joining. Thank you for the audience for this participation in this activity. Apologies for some technical lapses in the beginning on my side. It was a pleasure to have this with you, and I hope to see you on next occasion. Thank you, and have a lovely day.
Thank you.
Thank you.